Dr. Daman Langguth with me to discuss COVID-19 and its impact on patients with vasculitis. So Dr. Langguth is a practicing immunologist from Brisbane and has substantial experience with diagnosing, treating and managing patients with all sorts of vasculitis. So Dr. Langguth, welcome to the podcast. And first of all, do you mind just sharing with us your experience with patients with vasculitis?
Sure. So I've looked after people with vasculitis for a long time. I guess it's very hard as an initial, certainly registrar and consultant, to say one's an expert in vasculitis. It's something that, given the relative rarity of the disease, one achieves expertise and experience, the latter being more important, over time. And it rather does depend on where you practice and the patients who initially are lucky enough to be referred through to you. I mean, that the doctor's lucky, not necessarily the patient. And that it's been an active interest of mine. I and some colleagues last year, and for the couple of years before then, helped set up the Australian-New Zealand Vasculitis Society, and I think that's been a worthwhile aim. Obviously, however, just setting up a charity is the first step. The next step is to try and deliver things, and unfortunately the link with that and COVID-19 is it stopped us delivering things to some degree. But through the activities like this, which has been made available largely through free services, which is fantastic really, we can hopefully deliver information to people with vasculitis and their carers, so that we can deliver one of our core aims for Australian-New Zealand Vasculitis Society.
Yeah, fantastic. Yep. So now, as you may be aware, much of 2020 has seen and heard substantial news relating to COVID-19 and its impact on people. Do you mind explaining a little bit about COVID-19 and how it infects people? And is it a cold virus, first of all?
So, yeah, like any coronavirus are named because they do have a shape that looks a bit like a crown, and corona is Latin for crown. These viruses are very common. So they are one of a large number of viruses that lead to common cold symptoms. However, every now and then, much like influenza A and B, a virus arises that has not been present in any significant part before, may or may not bind to an original receptor, i.e. binds to something on the surface of a cell that's slightly different from other viruses, and has other attributes that allow it to be spread more easily. This means, and for this virus, that no human essentially had ever met this virus before. That's not that interesting, but what is interesting from the virus's point of view is it's actually good at spreading from human to human. That's arisen probably, like most viruses, in combination in other animals. There's good evidence to suggest this virus was circulating in other slightly changed form in other animals. And then, like most viruses, seems to admix. So in other words, what that means is the virus might get together accidentally in one host. And so there is theories that this might be a pangolin, which is kind of a cute little creature that looks a bit like an armadillo. Unfortunately, they're traded for natural medicine reasons and used as meat in very large volumes. And that pangolin may have been exposed to viruses that normally circulate in bats. Then essentially fused together, if you like, and by fluke, just by random combination, that new virus has meant that a person who breathed that virus in was actually able to become a new host. So this is really an accident. It's not a deliberate or designed thing. And once again, by fluke, human-to-human transmission can occur because, of course, if one human gets a virus and they succumb or they get a severe disease, well, that's tragic for that individual, but it doesn't mean much for the rest of society. And obviously, this isn't happening all the time. These are very rare events. So that this is the third time that coronaviruses have done this. And largely, we're going to be more at risk because there's more people on Earth and we travel around all the place. Because if people didn't travel very much, viruses wouldn't spread. We've even shown that inside Australia and not related to coronavirus. So that influenza A, which was at relatively high frequencies back in February, essentially plummeted to almost 0 cases Australia-wide. So that social distancing and isolation does actually control different viruses differently, and influenza and coronavirus are very well controlled by that.
Okay, yeah. So it's essentially similar to influenza in its what's called like antigenic shift, where it's gone through.
Well, yeah, like any virus, if you recombinate, so in other words, it's not quite the same as influenza, because influenza has some special properties in that the part of the virus that sticks to part of us seems particularly good at recombinating. And in fact, we've got tons of data on that. Coronavirus has actually achieved something quite different. It now binds to a different receptor called the ACE2 receptor, ACE number 2, and it's on the surface of lots of our cells in our airway. But the curious thing is it's also on the surface of lots of our cells in our bloodstream. And our bloodstream, of course, supplies pretty much every single organ. So then if you get severe disease, pretty much every single organ, and the really important ones like the lung, heart, kidney, and brain, can all cause problems or lead to problems. And that's where people who are very seriously affected, so not most people, only about 20% of people go to hospital, but that's a lot of people, especially if you're dealing with, say, the Australian population, 20 million, 20% of them is a vast number of people. And of the people that get sick, a lot of them get very sick. And that means that those people might need special procedures like kidney replacement, dialysis, intensive care, going on breathing machines, and suffer awful consequences like limb amputation, losing a leg, having strokes, and this occurs in young or old people.
Okay, so some of these symptoms sound quite similar to the symptoms and signs associated with vasculitis. Is there a correlation?
Yes. Well, this disease is really what has been termed endotheliitis. So, and it doesn't really matter whether it's big vessels or small vessels. In vasculitis, we've for a long time used what is called the Chapel Hill consensus criteria. So it's called that because that's where the first group of people got together to try and sit down to try and classify vasculitis, so that's useful for doctors to try and split things up. And the biggest reason is that's not that helpful for patients, but it's very helpful if you study these diseases. And then as we got better, we've studied them, and then we've got treatment more specific for the type of vasculitis they have. This disease doesn't really care what vessel's involved. It actually infects every cell called the endothelium, which line pretty much every blood vessel. So it's very much an inside disease. Most vasculitis affects not the very surface at the beginning, but either the very edge, and the medical word for that is the adventitia, or more commonly the media, which is the middle of the blood vessel. This disease caused by COVID-19 probably is only present in those patients who are sick, i.e. Gone to hospital or have high fevers. It causes inflammation in the very surface. And the very surface obviously is where the blood cells interact with the blood vessel. And this causes a whole host of potential complications.
Okay, so many people with vasculitis are currently on medications to either bring their disease into remission and to maintain remission. Are there any drugs that have been shown to either impact or have no known effect on the disease severity?
So luckily in Queensland and specifically from Brisbane, a colleague of mine who's a rheumatologist started an international data registry on rheumatology patients, so patients who receive immune suppressants for many and varied rheumatologic conditions. And we have more than 1,000 people in that database at present. So these are people unlucky enough to get COVID-19 and be on immune drugs. And we know so far that none of the drugs that we use in vasculitis seem to increase the risk. Okay. However, one drug particularly which people are on early does, and that's corticosteroids. So if you're on more than 10 milligrams of prednisone or prednisolone or the equivalent of other agents like dexamethasone, then your risk of COVID-19, i.e. not necessarily the risk of you getting it, but the risk of severe disease once you acquire it, increases significantly. Now, obviously, that's not a reason to suddenly drop your dose of prednisolone or prednisone, because presumably you're receiving that dose because there are no other ways in which to control your disease. But it does mean then, obviously, you might need to be much more cautious and appropriately self-distance. It certainly doesn't mean you should lock yourself in your house.
Okay, great. So what steps should people take then to minimise infection and transmission?
I mean, obviously, as an immunologist, I think from March, when lockdown first started, that's when I received a barrage of emails and phone calls. And it really is that our patients with vasculitis, whether or not they're on immune suppression, need to essentially what the government has said for once. The government's been pretty good. I think despite, people being regularly critical of politicians on all sides, Australia's done amazingly well. There are many things that could be improved, but our advice has been very good and relatively easy to listen to. Washing your hands and staying away from large groups of people. If you look at outbreaks initially that were modelled, and South Korea and Italy were sadly very good models, we know that large groups, it doesn't matter whether they're family, they're originally family because those are people who spend more time together, but workplaces where there are large gatherings of people are at high risk. And that's basically because if one person's infected, they get to meet a whole lot of other people. If your workplace has 2 people in it and you consider either ends of the room, your risk is very low because it probably doesn't matter that someone goes to work with COVID-19 and didn't know it. However, that does matter if you work in a place of 600 and everyone goes to the tea room and sits there. I've told my patients what they must do is before eating, not necessarily in their own home, but certainly if they're going out to eat, they should wash their hands, and they should wash their hands after they leave a place and when they get home. We have to be careful in that washing the hands does actually have potential downfall in some people, so that many of the chemicals we use in hand washing can, in a very small percentage, it's not a reason not for most people not to do it, but cause inflamed skin. And certainly if you do get inflamed skin, you should talk to your doctor, because some of the chemicals used in many of the alcohol rubs can actually trigger allergic or contact dermatitis. And there are many alternatives that can be found for you. So the most important thing is to not expose yourself. At present in Australia, that the chance of getting COVID-19 is exceptionally low. But we can help maintain that exceptional low chance by simply remaining 1.5 metres away and washing your hands frequently.
Okay, so it sounds like the chances of, as you mentioned, acquiring COVID-19 is exceptionally low. So does that mean that people are able to return back to their normal places of work, particularly for vasculitis patients?
Yeah, I think the risk is actually dependent not necessarily on the vasculitis, but more on other risk factors. So in other words, if you're on high doses of steroid, if you have damaged lungs, or if you have lots of what we call comorbidities, those are other diseases that you might have because of vasculitis or also have. So if you have abnormal kidney function, if you have diabetes or high blood pressure. However, those things often sound very scary to patients. We know that having high blood pressure or diabetes, the diagnosis of it doesn't appear to be important whether that's controlled or not controlled. They only double your risk of infection. So obviously, if the risk is very high, let's say you had a 1 in 2 chance of getting COVID-19, doubling that kind of makes it guaranteed. But if your chance is 1 in a million, doubling it to 2 in a million doesn't really alter your personal risk. And really in Australia, we're dealing with a risk that's less than 1 in 100,000. So that even if you're a super high risk person, your chance of getting it's probably much less, not much different. As I said, what's really important is if you are over 70, if you have structural lung disease. So in other words, if your doctor's told you have abnormal lung capacity, those are risks if you were to get the disease. Sorry, it's because my light has turned off, Mark. Been still for too long. Really it depends on a whole host of factors, but vasculitis per se is not a major risk factor for COVID-19. And only corticosteroids appear to be a major risk. We know that drugs such as called TNF inhibitors, examples of that would be Remicade or Humira or Simponi, and there are many others. They are used in some types of rare vasculitis, but not commonly. And they actually seem to offer protection. Certainly not a reason to start those drugs for this reason, but it appears from our observational databases that these drugs may have a protective effect.
Okay, great. Well, thank you very much, Dr. Langguth, for your suggestions and information today. It's been very much appreciated. Finally, what should people do that are all concerned about COVID-19 and its impact on themselves?
So I think you should talk to your family and friends. You should talk to your GP and your specialist about what's practical. Every single person has what's called a different risk appetite. It's based on your philosophy, on your background, a whole host of factors, and that what one person's prepared to risk is not what the next person is. I think you need to be open and honest and understand that if we can look at the hard facts, but humans don't always look at hard facts. They look at sometimes, what if this were to happen to me? What if I were to infect my grandchildren? All of these other factors affect us. So your doctor's going to be very good at giving you some statistics to say, look, if you've got damaged lungs, yes, if you were to get this disease, it would be much worse. And I think that then you need to then take that into account personally. I have been supportive of all of my patients. Basically, I've said to them, if you've got vasculitis or if you've got other immune suppressant drugs, I'll support you. The government guidelines say that all immunosuppressed people are at greater risk, but they really have to do that because it becomes almost impossible to issue advice on every single type of immune deficiency, of which there are hundreds, and a blanket sort of advice is all that can be given. But I'd urge you to discuss that with your GP and your specialist about are you really at greater risk? Many patients are not at greater risk, and I've said to them, please get back into normal society, obviously still sticking to the government suggested guidelines, but most of our patients are not at greater risk than other members of society. Remember, this is a virus, and most people with viruses, most people on immune suppressants do not get more viral infections. Certain types they might, but not most cold viruses. It's not something that you see. And if anything, this disease, it's not the virus that actually leads to your demise or can do. It's actually your own immune system. So if one's having a robust immune system or an immune system that as we age gets more excited by things that shouldn't excite it, can actually lead to your own demise. So it's you doing yourself in, sadly, and not predicted by previous damage to your immune system.
Mm. All right. Well, thanks again, Dr. Langguth, and thank you for your time.
Thanks, Mark.